and I'm going to make you co-host, and I'm going to go ahead and share my screen, and let's get started, everyone. All panelists. Okay. Mariana, can you see my screen?
Yes, thank you.
All right, guys. So welcome everybody back to session 4 of our 10-part CE free lecture series put on by my office, the Pain and Sleep Therapy Center. So I'm super excited to announce our guest lecturer today. She's absolutely amazing. But before I do that, I just wanted to go through a couple key updates and some house items. So first of all, I just want to thank everybody for logging in last Thursday. We had over 250 providers that logged in and learned about, the relationship between breathing and development and behavior and straight teeth. And so hopefully a lot of you guys got a lot of good pearls out of that. I know I had a ton of fun given the presentation. I had even more fun answering all your guys' questions afterwards as well. So if you guys did not get a chance to check that out, that actually can be found on our YouTube channel. So here's some links to our social media pages at Pain and Sleep. So we have a Facebook page, Instagram page, of course, and then our YouTube page. And our YouTube is kind of where we share most all of our kind of lectures that I give. So if you want to go on there and check out last Thursday's or any previous ones, by all means, feel free. I would be honored. As far as the remaining parts of the lecture series go, so we're not even halfway through, which is extremely exciting. I think we've packed these kind of 10 sessions full of some really valuable information, and none more important than the pediatric population, which we're going to hear more about today. So just some calls to action for the remaining lectures. We have Dr. Evans today. Tomorrow we have Suzanne King. She is a life coach, a former hygienist, and she's going to talk about creating contagious culture within everyone's office so that everybody is up and running and being able to kind of offer, your patients the best experience when we get back from the shutdown. Plenty of other lectures to go over, some highlights. Lauren's going to be doing a whole section on myofunctional therapy. I know a lot of you guys have been asking about that. So we dedicated a whole session to Lauren going over that stuff within the dental practice. And of course, I'm super excited for Dr. Joanna Green to talk about tongue ties later this May. So stay tuned for all of these dates, as the times may change if offices are opening sooner rather than later, but we'll continue to keep an eye on that and let you guys know if any changes are coming down the pipeline. So tomorrow's lecture is Suzanne. Like I said, you guys should all jump onto that if you want to look into creating this positive culture within your office. I think you guys will get a lot of pearls out of that. Today we have Dr. Mariana Evans, who I've worked with now for many years. And so she's been extremely helpful with, all of our patients in our general practices, as well as my Pain and Sleep Therapy Center, where Mariana and I do a lot of cases together. And so a lot of my TMD cases, a lot of my OSA cases that I do phase 1 on, Mariana actually does phase 2 on them. And so we work really well together, and we create sort of a multidisciplinary comprehensive treatment plan for our patients that I think is bar none, hands down, some of the best kind of plans out there. So, in order to make this even more personal for you guys, I wanted to, of course, no lecture with me is complete without, being able to showcase my beautiful family. So this is my beautiful wife, Renee. Renee actually is in active treatment with Dr. Mariana Evans. And so that's her on the left, not too long ago, about 6 months ago. And then here in the center is right when we got done with her, her moon skeletal expander. We got about, 8-9 millimeters of expansion there. And so she was kind of right in the middle. And then just a few weeks ago, she got her braces on. So I know Renee has been extremely grateful, as I have been, for this transformation that she's embarking on. So I know Dr. Evans is going to cover a lot more of this type of stuff today, so I'm not going to steal her thunder there. But I also wanted to throw this in while we were in Dr. Evans' office. We actually brought the kids. That's my 2-year-old Reese and my 4-year-old Bryce, who we brought them for obviously early orthodontics, who Dr. Evans is working with as well. So we had a little bit of a wardrobe malfunction. We had a little bit of a blowout in the office when we got there. So Reese ended up looking like the naked cowboy, and so yeah, we created this today. Who wore it better, the naked cowboy in Manhattan or my daughter? So just a little little bit of just joking there, but we're going to move on, and we're going to introduce Dr. Evans. So without further ado, I'm going to stop my screen here and welcome Dr. Evans. It is my distinct privilege and honor to welcome you to our series, and I'm looking forward to this this lecture as much as any of them. So go ahead and take over, and looking forward to hearing what you have to say.
Thank you, Ryan, for your kind invitation and for your kind words. It has been a really exciting time in dentistry, where we really are opening up to more interdisciplinary care, and it has been a great privilege to work with you and your team. So let me change to my screen. Okay. So today, So today we are going to continue talking about pediatric airway prevention and screening and orthodontic intervention. And the focus of my lecture today is going to be facial development and screening for abnormal facial development as it relates to pediatric airway in dental practice. Just 1 second. I think, okay. So sleep apnea, okay, perfect. Something happened with my computer. So sleep apnea is a very significant problem in our community today, in worldwide. And I think there is a lot of attention is growing in research, in dentistry, and in medicine, because there is a very strong link between Alzheimer's disease and sleep apnea. A lot of children have it. It's not only a problem in adults or in patients that are overweight. And if you have a problem like this in a child, it will affect child's intellectual development. As you can see from the study, 40 to 60% of children that have sleep disorder breathing under the age of 5 are very likely to need special education after age 8. So it is a major problem that we have to globally address. And pediatric airway requires a team approach. So it starts with screening. There is intervention that can be done by the dentist, by orthodontist, beyond medical professionals. There is a retraining stage where you have to work with the muscles. This is where our myofunctional therapy plays a very important role. And there is a preventive component where we as dentists and orthodontists will play a very critical role, because we will be able to identify patients with risks, skeletal risks, and address that skeletal problem in a young age, and hopefully make these patients less susceptible to sleep apnea later in life. So sleep apnea, pediatric airway requires a team approach. In our team, we have been working over the past 8 years very closely with general dentists, with sleep specialists, with pediatric and adult ENTs, with orthodontic surgeons, with myofunctional therapists, with allergy specialists. So there is a very important interdisciplinary care that has to take place, starting with the diagnosis and screening, and ending up with interdisciplinary treatment. So when we started our protocol in our practice, we started in a team environment with sleep physician and ENT, with who we actually work in our facility, in both of our offices in the suburbs of Philadelphia. And we decided that step one is going to be a comprehensive evaluation. What it means that the patient has to have evaluation with a sleep physician once there are some symptoms of sleep disordered breathing that are identified by either one of the specialists. They have to be evaluated for structural problems by orthodontists. They have to be evaluated for obstruction type of soft tissue obstruction problem by ENT, and then eventually we added allergy specialists to our team as well, because we found that the majority of the pediatric population had allergies, environmental allergies that have not been addressed in the past. Once this problem is identified, we look at the source of the problem. Or at that time we were looking at obstruction, so we were talking about obstruction. So is it the soft tissue obstruction that is causing a problem for breathing of the child? Is it a skeletal problem? So if it is a skeletal problem, then orthodontists play extremely critical role in terms of developing maxilla, developing mandibular, and modifying the growth. If it is a soft tissue obstruction, of course, the first line of treatment, and we know it well, is TNA surgery, if it is adenoidal obstruction or tonsil obstruction. And if a lot of the patients have a combination of skeletal jaw deficiency and soft tissue obstruction, so depending on the severity of the symptoms and depending on which component is the primary or more dominant, we would either start with orthodontic intervention, jaw development, or surgical intervention such as TNA surgery. And of course, just like for patients with periodontal disease, these patients require long-term follow-ups. All of these patients will require some kind of sleep study, whether it is a home sleep study for all the patients or in-lab sleep study for children, to make sure, especially if the symptoms are not fully resolved after intervention, to understand that sleep apnea is either fully resolved or does not reoccur later in life. Because a large percentage of patients that receive a surgical intervention will relapse with sleep disorder breathing later in life. So it is very critical to develop a team in your community, starting with screening and spreading the knowledge, awareness about this problem, and growing toward interdisciplinary care and long-term follow-ups for these patients. So the reason why we talk about sleep apnea and orthodontic intervention, because there is a very significant skeletal component to sleep apnea. And orthodontists, of course, are not treating sleep apnea. We as orthodontists are treating jaw deficiency. So if the patient has sleep apnea and that sleep apnea is associated with the skeletal risk factor, I think it's a very important part that the orthodontists are going to play in skeletal modification of the facial growth in growing patients, or skeletal modification of the facial structures in non-growing patients to address the skeletal component of sleep apnea. So there is a lot of research that already has been done in the area, and there is a lot of research that is being done right now linking sleep disorder breathing with skeletal deficiency. So on this slide, you can see a profile of the patient with sleep apnea, and you can see that the blue outline shows the normal physiologic proportions between the mid-face, mandible, and the forehead. Usually the upper jaw and the lower jaw have to be ahead of the forehead, have to be ahead of the glabella line. And in many patients with sleep disordered breathing, you have constriction of the nasal passages, you have constriction of the maxilla, and you also have a deficiency in the AP plane, as you can see on that slide. So I'm very, very proud to say that some of this research linking sleep apnea and facial deficiencies was done at the University of Pennsylvania, not orthodontic department, but sleep department. This research was done on MRIs before we even had CBCT technology in orthodontics in late 90s at the University of Pennsylvania Sleep Center. So it is very important, and now we are taking this research to the next level, and we are collaborating with Penn Sleep Department, ENT Department, and utilizing some data from the pre-industrial skull material from University of Pennsylvania Anthropology Museum, and comparing in the future this data with the patients that are normal and sleep apnea free, or the patients that actually have sleep apnea. So it's a very exciting time in research in Philadelphia right now. So when you look at the literature overall, beyond soft tissue obstruction from adenoidal and tonsillar tissue, you will find a few large cohort studies that actually found that jaw abnormalities are related to sleep apnea in children. So this study looked at a very large population of 4,318 subjects, age 5 to 6, and they found that there is a significant correlation between pediatric OSA and craniofacial morphology, specifically increased overjet, deficient mandibular growth, and maxillary transverse hypoplasia. They were not able to utilize CBCT technology at that time, but they looked clinically and they found the correlation between the posterior crossbite, which most of the time is associated with maxillary hypoplasia, and sleep apnea in these children, as you can see on those images. This is another study from Finland that was controlled for obesity. When they excluded any children that were overweight, and they found that a posterior crossbite, a mandibular retrognathia were as significant factors in children with sleep apnea as hyperplastic adenoidal and tonsillar tissue. When you look at the growth abnormalities in the intervention for the growth abnormalities in children in medicine, I think you will know that growth hormone is very, very important therapy for patients that have problems with skeletal, somatic, full body growth. In orthodontics, we are not utilize hormone therapy to grow facial structures. What we utilize is a physical, mechanical devices that are going to stretch the bones of the facial skeleton. So we utilize something called destruction osteogenesis, which allows us to stretch and open maxillary or midfacial sutures to address facial bones. And the younger the patient it is, the less interdigitation you will find in those sutures, so they will be less resistant to stimulation with the mechanical stretching devices, such as palatal expanders. So we want to utilize this technology in as younger age as possible. And of course, we also have now the opportunity to do the same treatment without surgery in adults using temporary implants, which I will touch shortly in a little bit. But the key of my presentation today is to spread the message, the importance of treating these children in a young age. So when you look at different orthodontic interventions, when we talk about skeletal deficiencies, we are not talking about straightening the teeth with braces. Braces do not correct the bone structures. Braces only align the teeth. We are talking about orthopedic treatment of the jaw structures in the vertical plane, in the transverse plane, in the AP plane. So as orthodontists, we are like a medical endocrinologist specializing in the somatic growth of the child. We specialize in the facial growth of the child. So we have the technology, we have the education to look at the face and diagnose any type of the skeletal deficiency in the transverse or horizontal plane, in the vertical plane, and also in the anterior posterior plane, AP, as you can see abbreviation here. So we want to know about every patient that we see, what is the skeletal development, what is the skeletal growth potential remaining if you are talking about young patients. Because we can change the green component, which is AP growth, we can change the vertical growth, and the most important change and the most significant change that we can make is actually at the transverse. So when you look at the facial growth overall, the blue line represents maxilla. The green line on the chart represents the mandible. So there is a very significant difference between the maxillary bone, which is part of the skull, and the mandibular bone, which is kind of a hybrid type of bones, because it will respond to the growth hormone, just like the long bones will respond, but it also has the teeth and dentoalveolar component. And it really, when you look at the chart, it significantly follows the growth harmoniously, the growth of the maxilla up to the age of 4. So when you look at the growth velocity of the maxilla and the mandible and the somatic growth in black line, you will find that the majority of the skeletal growth, or the large velocity of the facial growth, is going to be completed by age 4. And then there's going to be a plateau with very minimal growth up to the age of 12, and then you can see no more growth in the maxilla in the transverse, but there's going to be some significant jump in the mandibular growth. So we as orthodontists have to know this chart so closely and understand that differential growth between the maxilla and mandible in terms of age and time. We also have to know that the majority of the facial growth, or a significant portion of the facial growth, especially in the mid-face, in the maxilla, is going to happen before the age of 4. That's why it's so critical for us to treat and diagnose these problems in a young age, because after the age of 4, it's very clear the pattern of growth that the child is going to take. And if we can intervene in that young age, I think it's going to be a very important thing to do. So when it comes to maxillary development, it's usually the first step, because maxilla is the center of the patient's face, and it is a core structure to guide the mandibular growth. So mandible, in a lot of ways, is going to be affected by genetics, and it's going to also drag the maxilla with it if it doesn't grow forward enough. But to the large extent, maxilla is going to guide the mandible to grow forward and counterclockwise. So it's very important to know that maxilla, out of all structures of the facial skeleton, is the most moldable bone. So we can change it the most. And today with skeletal anchorage, we can even make a change in adult patients without surgical intervention. So this is a child with anterior open bite, with posterior cross bite. You can see at the level of the smile that the maxilla is extremely constricted. The mandibular teeth are lingually inclined, and you can appreciate that that maxilla does not fit that child's face. So after expansion, it looks very wide. It looks abnormally wide. And the reason why it looks abnormally wide, because we have a gummy smile, which is in a lot of the situation is going to be a normal physiologic phenomena before you have a full eruption of the permanent teeth, and especially here, you don't have maxillary canines erupted. So as you can see, that child is growing 2 years later. She's losing her primary canine on the upper right, and you can see that the smile is fitting the face much better than in the middle slide. So we in orthodontics sometimes have to grow the skeletal structures a little bit faster than they grow naturally. And we have to remember that there might be at some point of treatment disharmony of the skeletal structures with the facial soft tissue appearance. And it's important for the patients to be educated that this is a transitional stage and it's going to change. But as I said, it's very important to make that change starting with maxilla in a younger age. So a lot of dentists are very used to look at the teeth and also to look at the patient from the front. So one of the things, if you are going to start screening patients for abnormal facial growth, is going to be to start looking at your patients from the side. So ideally, if you put the head in the natural head position where you are looking straight at the horizon, and you drop a vertical line to horizon through glabella, this is what we call glabella line. You want to have maxilla and mandible, upper lips ahead of that line. So if you have any patient that has that upper and lower lip behind the line, they might be at risk of having a sleep apnea. So it's a very typical facial presentation for patients with sleep apnea. Although not all the patients with that skeletal pattern are going to have sleep apnea, but it's important for you to identify that clockwise facial growth and screen the patient for sleep apnea based on that skeletal risk factor. A lot of patients, parents, a lot of medical providers as well as dentists are always concerned about gummy smile. So gummy smile could be a normal physiologic altered passive eruption at the level of the teeth, but it could be pathologic. So you have to look, you have to start looking at your patients from the side, looking at the profile. Then you have to look at the smile, because smile is going to tell you a lot. If they have a gummy smile, the first thing you want to look is at the profile, because that gummy smile, as in this patient, is part of the altered passive eruption, because the teeth are not fully erupted through the gingiva, but in the same time, it shows you that there is a clockwise growth of the face of this patient. So maxilla is growing down and back because the mandible is deficient, and because possibly the child is a mouth breather. So there are a lot of factors for you to consider, but start looking at the aesthetics that will lead you to some significant skeletal risk factors that are going to be linked to breathing disorder. So in this child, there could be possible mouth breathing, open mouth posture that will lead to that skeletal growth, besides having a genetic component to mandibular deficiency. So that clockwise grower is very clear in the literature, is really correlated with the airway problems, because if the jaw structure is more back, that means that it doesn't grow away from the airway, so the tongue is going to be impinging on that airway space. So you have to remember that and diagnose these patients in a young age, because in a young age, before that mandibular peak growth, we can intervene and we can do something for these patients. So what did we do for these patients? We developed maxilla. We didn't really do much braces. You can still see that she needs braces, but you don't see gummy smile anymore, because we redirected the maxillary growth in the transverse and in AP, and we redirected the growth of the mandible. So this is our goal, patient after patient. And there are limitations where you cannot achieve the optimal result without the surgical intervention. So orthodontists are specialists that will be able to identify those patients that will require surgical intervention, but the mandible must come forward with surgery, or both maxilla and mandible must come forward with surgery. But before you speak about surgery with your patient, it's very important to do everything possible that you can do without surgery to modify that skeletal growth. So here is another patient with a severe gummy smile in the primary dentition. When you look at the profile, the same thing. You can see how far that maxilla and mandible are behind the glabella blue line. So what we did, we developed maxilla, we redirected the growth of the mandible. We didn't force the mandible to grow forward. We redirected the growth of the mandible by 90% changing the maxilla in volume, in transverse, and in AP. And his mandible grew forward. And so the same thing we can do for maxilla that is deficient in AP. A lot of children with allergies, a lot of children with severe nasal obstruction in a very young age will fail to grow in the AP in the midface. So a lot of these children will be midfacial deficient, as you can see in this child. So in this child, what we did, we expanded maxilla. We did nothing to the mandible other than uprighted posterior teeth. And we used protraction in conjunction with adenoidectomy to address his nasal obstruction and redirect the facial growth in the forward position. So you can see on the pre-treatment, his maxilla and mandible are significantly behind the glabella line. And after treatment, you can see that maxilla is ahead of the line and the mandible is on the glabella line. So that's the goal. And the window for that maxillary protraction is very narrow. It's very effective under the age of 8. But once you see these children after the age of 8, you're not going to affect the midfacial structures in AP as much as you would affect it in younger patients. You also have to remember that CPAP therapy for a child is not ideal treatment when it comes to facial growth. There are studies that confirm that positive pressure from the CPAP machine is going to impinge on the mid-facial growth. So this is a study that was done in Seattle that looked at 50 patients that were compliant with CPAP and 50 patients that were not compliant. And they found that the pressure to the mid-facial structures from compliant CPAP was altering normal facial growth of the maxilla. So a lot of these babies that are premature are going to be on the facial mask because they have immature lung development. So we see them later. We see the same patients late in life. So this is a child that was born at 28, actually 34 weeks, that has no family history of class 3 or anterior crossbite skeletal pattern and has severe midfacial deficiency. And parents said that he had, and parents MDs said that he had the facial mask in the NIC unit when he was born because he was a preemie. And those facial masks sometimes put too much pressure on the maxilla for these newborns. And maxilla is very soft in the newborn, so you can very easily collapse it. So we still were able to reverse the problem and bring that maxilla forward, as you can see on the post-treatment images. But if that child came to me after age 8, I would not be able to give the child the same outcome. So the age is a very important factor when it comes to the skeletal growth modification. So this is another child that came to me for class 3 correction. And as you look clinically in the intraorally, he has anterior crossbite. But when you look at his facial profile, it's not the maxilla that is deficient, but also there is a severe mandibular deficiency. And when you look at the lateral ceph, you can see that the airway is very underdeveloped. The airway volume is very constricted. And this patient does have sleep apnea, and he has also enlarged adenoids. But the adenoidal enlargement is not as significant as his jaw deficiencies. Interestingly, the mom was able to provide his ultrasound images, and the ultrasound image may not be very informative in terms of the mandibular relationship to this glabella line, although here looks like he had a closed mouth and you see severe mandibular deficiency. But what is interesting is that the maxilla was ahead of the glabella line. So something happened after the child was born, that the maxilla failed to grow. And the same thing, this child had the facial mask because he was born at 28 weeks. So he had this facial mask in the neck unit for about 6 weeks before the lungs were mature and before he was able to breathe. And that facial mask probably contributed to his midfacial deficiency. A lot of children that have that anterior crossbite are going to have it because of the functional shift to keep the airway open. And as I showed you earlier, you can see that his airway dimension is very constricted. So he's not getting enough oxygen during sleep when he lays down. So there is a theory that he probably is bringing his mandible forward to open that airway pharyngeal dimension and be able to breathe. So screen every patient with anterior crossbite for the functional shift, and the younger the child, you will see that a lot of these children have that functional shift. It's not a true skeletal +3, it's a functional shift. Just like you have a lateral functional shift with a crossbite, you have anterior functional shift in many children with small airway dimension that allows them to breathe a little bit better. So it's basically like a physiologic oral appliance for sleep apnea that holds the mandible forward and keeps the airway open. And of course, in younger children, we can change the dimension of the maxilla in transverse, and in AP, as we did here, you can see that the mandible is catching up and starting to grow a little bit better forward. So don't wait. Have these children be evaluated in a younger age, because in a younger age, the bones are more moldable. And as there is no question that we need more evidence and more literature to support the link between effectiveness of a different type of orthodontic treatment for sleep apnea in children and adults, but the literature is very clear that if the child is not breathing through their nose, the facial growth is going to be affected as they are growing. So nasal obstruction, open mouth posture as a result of mouth breathing that is very common in these children that can't breathe through their nose. And as I said, a lot of them have allergies or start with allergies, will lead to hyperdivergent increased vertical skeletal pattern, and definitely open bite in very severe cases. It will lead to maxillary constriction, to crowding in the mandible and in the maxilla. And it has to be diagnosed in a young age. And it's not only about the skeletal correction of these problems, it's about changing the function and addressing the nasal patency, retraining these patients to breathe through their nose. Because if you just correct the bone and you remove adenoids and tonsils, a lot of these children continue with habitual mouth breathing. So there is a team approach where the myofunctional therapy becomes very critical to retrain these children to use their facial musculature correctly and keep the lip sealed, and also retrain them to breathe through their nose. So this study was done by Dr. Solo in Denmark, where they looked at the mouth breathers and facial growth, and they found that there is a significant clockwise growth and vertical growth pattern in patients with mouth breathing, with significant development of maxillary and mandibular retrusion and deficiency. So again, team approach is very critical, and it's very important to start with screening. So let's say you are a general dental practitioner, and this is a new concept for your practice. This is very easy to implement in your practice if you start with screening. I think if you look at our population overall and you start treating children with this problem, I don't think we have enough pediatric dentists or orthodontists that will address this problem in young children that really need this treatment and are not being treated today in time. So I think eventually the general dentist is going to also play a key role in very minimal and initial treatment of these children, because we don't have enough providers when it comes to specialists like orthodontists or pediatric dentists that will be able to address population overall. So how do we screen this problem? Well, every child and of course every adult patient that comes to us, you have to screen, and the screening starts with facial evaluation. So as I said, it's important for you not only to look at the front of the patient's face and look for asymmetry, but it's important to look from the side at the vertical growth of the child. And as you know, there should be proportions between the forehead length, the midface, and the mandible. And if you see below the nose that that dimension is a little bit longer than the midface and the forehead, that's a problem. That means that the mandible and the maxilla are growing clockwise, are growing too much. So what it means the tongue is sitting on the mandibular arch and the child is not growing forward enough, it's growing down. And as the face is growing down and back, the tongue space is going to be compromised, and the tongue is going to impinge on the airway during sleep and even during the day. So look at the facial profile. Like here you have a child, and a lot of you will look at the child when they come for hygiene, and it looks to you, oh, the baby teeth are straight, we have some spacing between the maxillary incisors, we have minimal spacing between the lower anterior teeth, okay, no crossbite in the back, no crossbite in the front, no lip tie, no tongue tie. I think this child is okay, and you do your cleaning and the child goes back for another 6 months, and 6 months for a facial growth is a significant amount of time. In 6 months, me as an orthodontist, I can do miracles in terms of facial growth in a 4-year-old, in a 5-year-old, in a 6-year-old. So you are going to miss the most important part of this patient's facial growth if you're just going to look at the teeth. And of course, the panorex is not going to tell you much other than overlapping follicles. So if you see that the follicles of the maxillary canines and the maxillary premolars are overlapping, that's the red flag for you that the maxilla is deficient. So start looking at the face, start looking at the crowding in a different way. So if the child has the vertical growth increased, as you can see in this child, and you can see from the side, maxilla and mandible are deficient in the AP. You can see from the front that this child has a gummy smile, that's increased vertical growth. So something has to be done for this child. And it doesn't mean that this child has to have airway symptoms. It could be 100% asymptomatic child. It's not only about today and today's symptoms, it's about tomorrow. So you have to project 20, 50 years from now, and if anything can be reversed and modified in that facial growth, it has to be in a younger age. So we use a pediatric sleep questionnaire in our practice that was developed at the University of Michigan by Dr. Chervin. And it's a very good start, and I will be happy to share with everyone if you want to email me this form. And I know that Ryan probably has it as well. We modified it, we use a little bit more questions than you find on the form. But it's a good start for you to see what actually is happening with breathing in your pediatric population, and also the frequency of this problem. So one of the part of that questionnaire is going to look at the congestion and the quality of sleep. And that is basically the questionnaire that was validated with the sleep studies. So if the patient answers some of these questions yes, such as has your child ever stopped breathing during sleep or snoring all the time, a lot of these children will present with sleep apnea on the sleep study. So it's a very good start, and it's very easy to implement. It's 30-something questions that your parents are going to answer. So it's asking about snoring, it's asking about sweating, bedwetting, restless sleep, it's asking about congestion. All of these are very critical questions to screen a child for sleep apnea. It's also incorporates some daytime symptoms. In other words, sleepiness during the day. Is your child taking naps during the day? Fatigue during the day? Growth abnormalities. Did your child stop growing at normal rate over the past few years since birth? The weight, is your child overweight? So some of these questions are very important for screening your patients. And it will do a little bit of preliminary screening for ADHD and some kind of attention disorder that some of these children will have because they are sleep deprived and because they are not getting enough oxygen during sleep. So going back to my patient that I presented earlier, 4-year-old with almost normal looking occlusion clinically, without the crossbite, without severe crowding, but facially you can see bimaxillary retrusion and gummy smile. So when you go forward to his lateral ceph, you can see severe adenoidal obstruction. And when you go back to the way the mom answered the questions, you can see that she answered a question yes to while sleeping. Does your child ever snore? Yes. While sleeping, does your child snore more than half the time? She answered yes. While sleeping, does your child have heavy, loud breathing? Yes. Have you ever been concerned about your child's breathing during sleep? And mom answered yes. Does your child usually sleep with open mouth? And she answered yes. Do any allergies affect your child's ability to breathe through his nose? Yes. Does your child have a problem with sleepiness during the day? And she answered yes for a 4-year-old. Does your child complain that he or she feels sleepy during the day? Yes. A 4-year-old complaining that they are sleeping during the day? Totally abnormal. So this is self-educational form for the parents. So some of them are going to be very alert and very concerned about after filling this out. This child often is easily distracted by extraneous stimuli. This child often fidgets with hands and feet in the seat. So a lot of these children will act like they are hyperactive because they are sleep deprived, they are exhausted. So they will not always be falling asleep in the middle of the class. They will be hyperactive. That's normal reaction to sleep disorder in children. This child often has difficulty playing or engaging in leisure activities. This child often is on the go or often acts as if driven by a motor. She said yes. This child often has difficulty awaiting her turn, and this child often interrupts. So a lot of these things could be part of normal child, but a lot of these things together with the way the parents answered about the sleep of the child and congestion are going to be related to sleep disorder. And so once you have this document, and it is scientifically validated document, this is your first step to start communication with the pediatrician. So this is a document that is going to alarm not only the parents, but it's going to make you as dentists responsible to be proactive and make a referral for this patient to the right specialist. So obviously he came to me for orthodontic evaluation because he was screened by the general dentist that identified these symptoms as a problem and identified the skeletal abnormal growth. So then the child was referred to me because that dentist knows that we work in a team. So we evaluated this child from the skeletal component, and we also screened the child for sleep. It was the validated questionnaire, and we took an image because mom wanted that image done because she was already concerned. You don't have to take a CBCT on a 4-year-old, it's not necessary. And we saw huge adenoids. And as a matter of fact, we took a pre-CBCT screening image, which is basically equivalent of a bite wing, and it showed large adenoids. And when we saw those large adenoids, we decided to do a full limited scan, and you can see here that there is severe adenoidal enlargement. So maybe there is nothing on my end that at this point of this patient's life I'm going to do anything orthodontically, but guess what? This is an absolute referral to the ENT because of this abnormal symptoms and abnormal findings on the CBCT. So this child ended up seeing the ENT, and the ENT prescribed the nasal Flonase spray, and the ENT said, let's try with expansion. And the reason why, because we collaborated on a lot of cases, and they saw the outcome and response from nasal respiration and adenoidal shrinkage from orthodontic skeletal development alone. And they requested, they referred the patient back and they said, we want you to expand. Let's get those skeletal structures addressed. And we know also that those skeletal structures respond very fast. Within 6 months, the skeletal problem of maxilla is going to be almost healed. So we, after expansion, so we expanded, we applied mandibular teeth, and you can see the clinical outcome. And guess what? The symptoms went away after this intervention. And also we found that this child didn't need the surgery afterwards because we saw some shrinkage in the adenoidal tissue. So what you see here is that mandibular appliance that required uprighting of the posterior teeth. So a lot of times mandibular teeth will compensate and will be lingually inclined when maxilla is deficient, and you must upright those mandibular teeth to get maxillary correction to the maximum. So we uprighted the teeth, and the younger the child, the better response they will have. So mouth breathing is a very important thing for you to diagnose. A lot of these patients will have a lot of plaque buildup around anterior teeth, will have crowding in the front because the mandible, basically the tongue sits on the mandible and there is no development of the anterior portion of the maxilla by the tongue, which is usually developed by the tongue. And when you look at the orthodontic therapy for crowding, so in other words, look for crowding. There is not a single paper today that says that non-extraction dental alveolar expansion with braces versus extraction of the premolars, which is a very common treatment modality for crowding, is going to help the patient with breathing. So there is not a single paper today in the literature that says that if you extract premolars or if you straighten the teeth with braces alone, that the airway symptoms or any type of sleep apnea symptoms are going to be improved. Unlike when you look at the skeletal expansion, when you open the midfacial sutures, we open maxillary suture, there is a lot of literature supporting this treatment in terms of improving nasal respiration, improving sleep apnea symptoms. So we have to do more research by opening those sutures. Anatomically, you cannot separate the nasal cavity from oral cavity because maxilla is the center of the midface. It's basically holds the base of the nasal cavity and it's the roof of the mouth. So once you open that midpalatal suture, and the mid-palatal suture opens enough, you are going to have an effect of nasal respiration because you are going to open nasal passages and you're going to decrease the nasal resistance. And that's what the literature is starting to show us. So today, if you're going to have a patient with crowding and that crowding is there because of the bones are deficient, you can significantly change the skeletal structures of the maxilla and the mandible, and you can avoid extractions, and you can also avoid orthodontic surgery in a lot of these patients. And so by opening the mid-palatal suture, you give more space for the tongue and you open the nasal passages for better respiration. And guess what? For this patient, we did not need to remove the adenoidal tissue because adenoidal tissue shrank after the nasal respiration was re-established after expansion. So there is a lot of literature today that supports expansion and in conjunction with adenotonsillectomy, but we do need more research in this area. And we have to remember that you have to do something to the mandible. It's not only the maxilla that, of course, maxilla is the only bone that has the suture. You can open it in the mandible, you can, but you have to apply those mandibular teeth, as you can see on that slide, to achieve proper maxillary expansion. And there are still a lot of unanswered questions with maxillary expansion because a lot of these studies have used old traditional protocols where we use two supported expanders. So now, even with those two supported expanders, the literature shows that they are very effective for patients with sleep apnea. So here is basically systematic review where they looked at studies with palatal expansion over and less than 3 years, and they all show that there is a significant improvement in sleep apnea parameters. But today we have the technology where we can place those little pins or temporary anchorage devices, and we can achieve much larger skeletal correction in those midfacial structures. So in my practice, in younger patients, I use bonded expanders. And if I find one expander that gives me a better result than bonded expander in a young child, I'll switch. But today I have not seen one traditional two-supported expander as a type of hierarchy that is going to give me the result that I get with bonded expander. When it comes to all the patients after the age of 12, after they have full set of permanent teeth in the mouth, that's when we do the skeletal anchorage for expansion, as you can see here, TAD expander, because you get much larger expansion with those devices. And there are already studies that prove it, that there is more expansion in the bone that you get with the implant supported expander versus two supported expanders in adolescent patients, for example. And as I spoke earlier, by opening the mid-palatal suture, you decrease nasal resistance. So you improve nasal respiration. You improve nasal respiration, you decrease nasal resistance, you basically decrease the collapse of pharyngeal musculature during sleep. So this is some of the data from our practice where we look at 27 patients, and we found that we get a lot of nasal expansion with those bone-supported expanders. So here we have 50% of nasal expansion versus traditional expanders, you would probably achieve 5 to 20%. And the age is very critical factor because the younger the patient, you need less implant, you need less invasive techniques to utilize for expansion versus in adults, you have to use a little bit more invasive approaches to get it. And non-surgical expansion is going to give you much better outcome in terms of midfacial correction versus with the surgery in all the patients, you're going to make your cuts below those cheekbones and it's not going to be the same effect on the midface cosmetically from the respiration side as it would be with the non-surgical protocol. So I'm going to skip here. So without surgery, so this is the patient that was treated without surgery, and it is showing to us that it's very stable. So without surgery, we expanded her a lot, and that result is stable 3 years after the surgery. And if you do it right and you plan it right, it should not really affect the facial aesthetics, although if you're going to expand the nasal cavity more than 5 millimeters, you're going to see some changes with the soft tissue. But usually with all the proportions of the face, it's not going to be as dramatic as you can see in this patient, but it could be a concern. So the specialist has to be involved in educating and determining whether the patient is a candidate for this treatment. So there are some minimal invasive surgical interventions available to us today that allow us with less invasive surgery to achieve a skeletal expansion in adults. And some of these techniques are being improved at Stanford University on the West Coast. And they already looked at the sleep apnea parameters, and they found significant improvement in sleep apnea parameters. A lot of functional appliances that bring the mandible forward are being studied over the years in terms of the TMJ remodeling, and also now for the airway. And the effectiveness of these appliances, we don't have a single randomized controlled study. So that's what we are looking for to really answer the question if they are effective and if we should be utilizing them. And in order for us to consider orthodontic skeletal development, we must find jaw deficiency. So we can do skeletal development if the jaw structures are normal. But very often in those patients with breathing problems, we find that there are jaw deficiencies, and we treat it. We have to determine whether those procedures will be done prior or after TNA surgery. It's very important to evaluate these patients for this treatment with residual apnea, when they have residual apnea, so when TNA surgery was not effective. And also in mild OSA cases without enlarged adenoid and tonsils, I think this will be the first line of treatment when it comes to correcting and treating sleep apnea. So a lot of the patients will have postural adaptation, as you can see in the patient in the burgundy shirt, like the head is forward. This child is 16 and he has a sleep apnea. Clinically, you can see that both of the twins have AP deficiency, but the twin with sleep apnea has significant more AP deficiency than the other twin. And you can see clinically, you might not catch those patients in your dental practice when they come for a checkup, because these 16-year-old twins were never referred to an orthodontist because the dentist felt that the occlusion was acceptable. Well, some of the jaw structures you cannot really diagnose from clinical evaluation alone. That's why we recommend orthodontic specialty evaluation for every child under the age of 6. So this child has sleep apnea and has nicely aligned teeth, but when you look at his bone structures, and a lot of the patients have a compensation at the level of the teeth when the upper teeth are buccally tipped and the lower teeth are lingually tipped. So once you decompensate, they will be in a crossbite. So here you can see his x-ray, and you can appreciate that his upper molars are slightly buccally tipped, and once you upright them, that maxilla will require expansion. So when you look at a lot of these patients, they will have constriction of the jaws, and they will have an AP deficiency of the jaws. And your question becomes like, what is going to be necessary for these patients? So because the bone is so moldable in the transverse, our protocol is to address the transverse component prior to addressing AP, because addressing AP in anyone older than 60 is a surgical intervention. And in this particular patient, we expanded him 4 millimeters in the bone, and his sleep apnea resolved. He was not receiving this treatment for cosmetic needs. He was doing it for sleep apnea. So once sleep apnea resolved, we don't go for maxillary mandibular advancement. We stop right there. And in the future, if his sleep apnea will redevelop and come back, of course, he probably will be a candidate for MMA surgery, because it's a skeletal problem. So a lot of these patients will have anterior crossbite crowding. take a lateral TAF or CBCT to look at the adenoidal tissue. And we will expand them more than traditionally we are taught to expand, because traditional protocol of less than 5 millimeters will not be effective for these patients. As for this patient, 2 TNA surgeries. After TNA surgeries, her adenoids regrew. And after 3 rounds of expansions, she responded and her sleep apnea went away. And today, we can even improve periodontal support with this treatment. There is no other orthodontic treatment today that shows you that it's going to be more bone after orthodontic treatment than before, other than the surgical PAO or SFOT treatment. With this protocol, which we discuss very closely in our courses, we get apposition of the bone on the buccal of the upper maxillary teeth without surgery. And it's a new expansion protocol that we are working with for the past 5 years. So here is the deficient maxilla, and you can see post-destruction how much change you can make to that maxilla beyond 5 millimeters. And this is how it looks clinically. The occlusion looks better. So you can also have improvement at the level of the sinus congestion, and as you can see on this slide. You also have to look for the tongue ties. A lot of these patients with sleep apnea and also with abnormal facial growth will have tongue tie that was never diagnosed, was never addressed. So we try to diagnose and address ankyloglossia in infants when possible, and if they come to us too late, you have to do it in all the patients. So there is more and more new literature coming out on ankyloglossia that I can share with you at another time, but don't only look at the teeth or the hard tissue or the soft tissue outside the mouth. Look at the soft tissue inside the mouth, because you will find a lot of problems that are going to be correlated with the jaw growth. Like in this patient, for example, the tongue pushed the teeth forward because the tongue problem was not diagnosed. So we had to release the tongue in conjunction with myofunctional therapy, and then we were able to reverse, expand maxilla, and then we were able to reverse some of that severe anterior crossbite that is, in a lot of cases, a surgical case. So look for the craniofacial dental adaptive phenotype. Some of these patients will have crowding and crossbites, but some of them will have this and will not have sleep apnea. Like this patient on the left with large tonsils, she does not have sleep apnea because she is adapting, she's compensating with open mouth posture. And she's overusing her perioral musculature and constricting those arches even more. That's why she has crowding. On the other hand, you will have children with forward head posture, as I discussed earlier, with bruxing. Severe wear of the primary dentition is not normal. Some wear of the primary dentition is physiologic, but severe wear where you will have a decrease in the vertical dimension should be a red flag for possible sleep disorder breathing, and these patients have to be evaluated by a team. And some of the children will have spacing. So some of the children will have anterior crossbite or spacing that have a little bit stronger musculature of the tongue, and they will push the teeth apart to keep the patency of the airway and even bring the mandible forward if the mandible is deficient into anterior crossbite, as I talked to you earlier today. So spacing between the teeth is also something to look for. Like out of all these 4 patients, the only one that doesn't have sleep apnea is the one with crowding. So the one that is very obvious, the one that you always will send to the orthodontist. That child has severe malocclusion but does not have sleep apnea. The rest of the 4 with wear, with spacing, with forward head posture have sleep apnea. So what I want to say is that every child, do not discriminate. Every child must be screened for sleep disorder breathing, because you will be surprised how many that don't look as bad actually have it. So you also have to look beyond the teeth, look at the tonsils. The problem today is that the traditional classification of the tonsils is only in the horizontal plane. what you see in the mouth. But those 3D images are very helpful for us to evaluate tonsillar hypertrophy in the AP direction, because a lot of these tonsils are positioned below occlusal plane and are obstructing the airway below occlusal plane, not behind the tongue, not above occlusal plane. So you have to do your comprehensive evaluation, and imaging is part of it. So some of the children will have AP deficiency, as the patient on the right, where the tonsils will be obstructing the airway, not because they are big, but because the jaw structures didn't grow forward enough. And on the left side, it could be the jaw structures did grow forward enough, but the tonsils and adenoidal tissues are inflamed and enlarged. So you have to look for these things. Like, for example, if both of these children have sleep apnea, the one on the left is going to respond well to the surgery, but the one on the right is not, because that's the child that needs your skeletal 3D development and growth of that maxilla and the mandible forward and in the transverse dimension. A lot of children will be seeing medical providers for other reasons, like some of them will have eczema. Like if the child has eczema, they could see a dermatologist 4 times, but just like us, dentists don't screen children for airway disorders, dermatologists don't either. So this child is seeing dermatologists from age 1, and at 11, he comes to me for orthodontic evaluation. We screen him for sleep apnea, he fails the test. We take his CBCT imaging, we see large adenoids, large tonsils obstructing the airway and anterior crossbite. So imagine I don't screen the child for airway problem, I put him on the face mask and I push that mandible back into obstructed airway. What's going to happen to his sleep quality? That's the child that is going to rip off that face mask during sleep. So you have to screen them comprehensively. So we were able to do a surgical intervention after sleep study, confirmed sleep apnea. He had his TNA surgery, then we did expansion, and we got a very nice result, and his sleep apnea is resolved. One is the optimal time for jaw correction. Of course, in the primary dentition, where you still have the follicles of the teeth that have not expressed or overgrown down and backward too much and increase the vertical dimension. So you want to diagnose and intervene in the primary dentition before you see the problem of lower incisor crowding, erupted lower incisors with the periodontal problems. Those periodontal problems are avoidable if you correct the jaw problem in a younger age. So age 6 is already too late, because the lower incisors are the first permanent teeth to erupt together with the first molars. Once those lower incisors erupted like this, those are compromised lower incisors. You have missed the window of improving that periodontium. So it's too late when the lower incisors are already erupted. So you have to think in a different way. So I tell the patients, I want those lower incisors to erupt just like parallel parking. I want the space on either side of the tooth to make sure that you have nice juicy periodontium surrounding the tooth, and the tooth is positioned in the center of the bone. Once the tooth erupts crowded, as I showed you in the previous slide, it's too late. You may expand the maxilla, but there is not much you can do to those lower incisors without surgery. So this is a very good example. This is the siblings. An 8-year-old and a 6-year-old was the lower arch development. So you can see the same device, the same amount of 11mm screw expansion. And you can see that the expansion that I achieved in the primary dentition is much more significant than the expansion that you can achieve in the mixed dentition, or in the especially late mixed dentition. So the teeth will grow straight if you, without braces, if you address those bone structures in a young age. And we have more and more case-based evidence to support this, concept. So you want to expand those maxillary arches by opening the sutures before those permanent incisors come in, because I don't want to move those incisors into cortical bone when I close the diastemas. I don't want the child to have the diastema. I want that incisor to erupt into the proper position, into the center of the arch, without me orthodontically moving that incisor into the midline. So I want to say that malocclusion is a symptom. And malocclusion is as significant as scoliosis or poor vision. So you can't miss the window of the opportunity to correct this problem in a young age. I know we don't have a lot of evidence treating younger children. If there are any schools that are participating in this webinar and you would like to look at our data, because we do treat children below age 6, we will be happy to share with you and have any of the schools look at our data and the results that we get, because now this is 10 years since I'm practicing, so I have a data of at least 9 years where we followed these patients from phase 1 to phase 2, and a lot of them even had a sleep study. So I think it's very important lesson for respiration, for periodontium, for facial harmony. You have to treat these children in a younger age. It's too late to do it after the age 8. It's too late to do it after age 12. And absolutely, you have to and must avoid a surgical intervention. And you cannot do it alone. You must have a team to do it with. And I want to thank you, Ryan and Ryan's Pain and Sleep Center and your group for inviting me for this webinar. And I am free right now to answer any of the questions. So I'm going to exit. Thank you. So, okay, so we have 41 questions.
Yeah, I was about to say, Mariana, are you looking at all the questions? So there's...
I didn't, I'm going to start looking. So how do you guys, and I see Kevin Boyd joined us. Thank you so much for joining. So let's would you like me to go question by question, or would you like to start a discussion?
Yeah, so let's start a discussion. I think that'd be great. So for those of you who are still on, for those of you who stuck around, thank you so much for sticking around. I know this was supposed to be an hour, but when Dr. Evans and I get going, we just don't like to stop. So for those of you that stuck around, we'd be happy to stay on here and answer all of your questions. And we have the distinct privilege to have a local celebrity in our panelist discussion here. Not only Dr. Evans is here, but Dr. Kevin Boyd is here as well. And Dr. Boyd is a pediatric dentist out of Chicago. And so he has become close friends with him over the years of in the airway circuit. And so he's on here as well, so he can share some of his expertise. So why don't we just open it up? Why don't I give you guys some questions and we can kind of open up and just have a little discussion. What do you think?
I think that's awesome. Mm-hmm.
Okay, so I mean, one of the first questions is a lot of people are asking, what is the earliest time to send their kid to see someone like you?
So I think you want me to answer, or?
Yeah, why don't you answer first?
So I, as a periodontist, see young children, infants, for frenectomy very often, just like you guys do in your center. So I think now that we see newborns, we are able to educate parents about the importance of breastfeeding, the importance of weaning into solid foods, the postural positioning of the baby during nursing, and also not using the car seat for sleeping, just for transporting the child. So I think a lot of these tips and concepts we introduce to parents. I think we should even have some lectures for pregnant women and for parents that are starting a family, so they learn about the growth and development from the very beginning. Because when we see patients, even after the age of 2, so many things that could have been prevented, it's already done, the damage is done. So I like to see families when they bring the infant to me, even if that infant doesn't need to have frenectomy, just for educational purposes, to teach them how to raise a healthy child, at least within the first 2 years of their life. But in terms of the intervention, I think, of course, orthodontically, we are limited when we can start the intervention. From the development standpoint, we can see them at any age before 4. But when we can do something for them, I think in orthodontic practice, it could be age 3, 4. And I know that Kevin, as pediatric dentist, is seeing them even younger in terms of intervention.
Yeah. So Kevin, why don't you tell us a little bit about that from your perspective? Because you see them, you see them well before Mariana does. But one of your comments during the lecture was, what was the gestational age of the fetal ultrasound? And I think, that's what we're finding more and more is that, we're looking at these things in utero now. So can you touch on that for just a second?
Yeah, thanks so much for inviting me. Can you see me? I can see you, but
Yeah, I can see you.
Okay. I say age 7, that's when the American Association of Orthodontists says a child should be seen for their first, ortho eval. I say frequently age 7 is a geriatric patient in my practice. So Mariana and I have been doing work with pre-industrial skull collection at the Penn Museum for over 6 years now. And we actually see, stillborn fetuses from 300 or 400 years ago. And, suggesting that in utero, maybe till fairly recently, kids were born with bimaxillary protrusive jaws. I mean, we have a small collection of them at the Penn Museum of these fetuses, and both jaws are wide and forward, even the stillborn ones. So, another thing that I'd like to bring up, in addition to what Mariana said about the importance of, pregnancy wellness, which includes not just a mom eating well and nutritiously and certainly getting adequate activity, but the third component of pregnancy wellness is the mom's breathing. There's something, and you can Google it. I can send you papers, but it's called gestational apnea, that women who have sleep disordered breathing or breathing disordered sleep, whatever you want to call it, during fetal development, the placenta actually, robs the fetus of oxygen. The mother, that's the only nutrient, and oxygen is a nutrient. Oxygen is the only nutrient that the mother has preference for. It's like the flight attendant saying, put the mask on yourself before you help your kid. So the fetus does not get priority towards oxygen, and a little bit of oxygen deprived because of maternal snoring, and there isn't a lot of research on this. It can actually harm growth and development of not just the long bones, small for gestational age, but the craniofacial bones as well. So this could be part of the contributors to why modern societies are, predisposed early in life for kids to have malocclusion. The other thing is men get sort of off the hook, like, oh, well, the mom has to take care of herself. Well, there's also an avenue of research that's being discussed more and more called preconception wellness. And that means that the man has to take care of his sperm too. And that means cut back on the drinking, smoking, work out a little more. If you're thinking of having a baby, it isn't just the mom that's got to take care of herself. So, that's all I'll say about that. Mariana, and I disagree. She sees as many real little kids as I do. I maybe started out doing that more, but boy, some of those cases she's showing shows that and I want that to be an inspiration to orthodontists who aren't seeing little kids, to pediatric dentists who aren't seeing ortho patients and just putting out sugar fires, which is a whole nother issue that I'd like to talk about at some point. Mm-hmm. But also general dentists, like Mariana said, they're going to save the day. They are the workforce. So, that's all I have to say about that part of it. But, thanks for inviting me.
Yeah, thank you, Kevin. That was amazing. So Mariana, and Kevin as well, a lot of questions on, are you putting together any data for babies that were born prematurely? and that midfacial deficiency that you're seeing. What are your thoughts on that?
So I think we take the birth history for every patient that comes to us. So we already have a good number of patients that present with maxillary deficiency and had to spend at least 1 week in the neck unit. So I think at this stage, it's a good idea to unite the forces and unite the data from multi-orthodontic practices. It's not a very difficult study to do if we can engage other orthodontists and possibly do a study looking at these patients and the family history of class 3 and the clinical presentation of the bimaxillary retrusion and make a link with the facial mask, because facial mask right now is actually being redesigned in Israel. So hopefully it will be released. It's going through FDA approval. It's going to be applying a little bit less pressure to the midface of the infant. But I think the medical doctors are not very aware of this problem, skeletal problem, and the link. So we have to educate the medical doctors, especially pediatricians and neonatal pediatricians, about this side effect, so they become more proactive, developing something that is not going to restrict the growth of the midface. Yes.
Yeah, that's great. So we had a midwife from Poland who logged in today and said that your commentary was very interesting to her. So that's pretty cool. How many different specialties we're touching here. So Mariana, a lot of questions on, your protocols and things like that. And, I'd like to let everybody know that Dr. Evans is a world educator. She hosts courses all the time here in Pennsylvania. So if you guys want more information on her protocols and exactly the type of things that she uses, I'd highly recommend, looking her up and getting involved in one of her courses. She does hands-on courses. She does didactic courses. And I hear she's building a little something out of her home, which may be able to house some courses in the future as well. Mariana, do you want to talk any more about kind of protocols or expanders? I know there's a ton of questions on expanders and the types of expanders. And I think what I've learned from you over the years is you're using tools in order to achieve, results, but it's not necessarily all about the tools. It's more about the decision-making that goes on, the evaluation, and 95% of your effective treatment plans come down to your effective diagnosis right before you get started. Can you just touch base a little bit about that?
Yes, so there are different type of devices today to achieve expansion. So there are two supported the expanders, there are hybrids, there are pure bone supported expanders. So age is a critical factor in terms of recommending these devices. So if it is a child that is still growing in the mixed, in the primary dentition, we often will utilize tooth supported expander. But even if you compare the tooth supported expanders, such as banded devices like Hyrexes versus like bite plate type of expanders, like acrylic types that I like, you see a difference in the skeletal correction. Of course, for the doctor, it's easier to use banded appliances, and now the technology is evolving to make it even easier on us and on the patient. But I have yet to see with the banded appliances the same result we get with bonded expanders. So my protocol of expansion starts with diagnosis. So I start with the question, does the patient need expansion? And a lot of the orthodontists often will agree, yes, this patient needs expansion. But then the second question is by far the most important, is how much this expansion, this patient needs expansion. So measuring how much expansion you need to achieve a proper improvement in respiration, proper functional occlusion, good aesthetics is a very important question, and that is not answered with traditional diagnostic tools that we have. So traditionally we look at the molar inclination and we don't look as much at the front of the jaw. So we developed a new protocol called the 4D morphotropic protocol that is looking at the shape of the jaw, at the anterior portion of the maxilla, at the posterior portion of the maxilla, because a lot of the patients will only need more expansion in the front because the tongue is all the way in the back, developed properly, maxilla in width, and the anterior portion of maxilla is not developed. So we use a lot of 3D images where we do virtual setup of the dentition to determine how much expansion they need. And of course, the amount of expansion that the patient needs is projected over a longer period of time. So we are becoming more conservative. We don't want to expand a 4-year-old to a 12-year-old jaw size. So we calculate a lot in a young age. And when you have the tooth buds, then you look at the face, you do comprehensive evaluation of the need for expansion. You can really determine how much expansion they will need. How much expansion they need will be determined, meaning how many expanders they need, because we know each expander is limited, how much you can widen the bone, and what device they will need. And we project it over a period of time. So we do incremental protocol, we do it gradually. In the end, you saw the results that we were able to achieve a lot of expansion. But for the orthodontist, the answer is that we use a lot virtual setup with utilizing CBCT anatomy models to determine how much expansion they need, and not the traditional orthodontic analysis. Mm-hmm.
Hey, Dr. Evans, I'm going to put you on the spot here and say, is it safe to say that orthodontists, they all need to be working with CBCT?
Mm-hmm. Well, I think to answer the question, you know, my answer is yes. But when I look at myself, the way I practice, I needed CBCT to understand how to look for the problem. But today I could see a lot of patients that I will say they need this much expansion. I want to say that you don't really need CBCT to determine how much expansion you need, but you need CBCT to learn, to know how to do it. But CBCT shows you many other things that you need to know. I think we are clear right now that we are going away from the traditional lateral SAP analysis that a lot of times will mislead us in the proper diagnosis. So the CBCT shows you the transverse, the vertical, the AP all together, shows you the nasal cavity, the pharynx. So it gives you so much more information, sinuses, that you need to make your diagnosis. So I think the answer is yes. I think every orthodontist should be using 3D images to diagnose and treatment plan the cases without a question, especially when we use bone-supported expanders. That's a must.
So I'm going to turn this one over to Kevin because him and I have good conversations around mouth breathing. So one of our attendees said, many thanks for the wonderful lecture. Are infants supposed to breathe through both their mouth and their nose? And, you know, with a resounding absolutely not. I'm going to let Kevin take that one because, you know, we see this is the start of, you know, the stuff that we then have to treat. So, you know, nobody better to speak about that than Dr. Boyd.
Thanks, Ryan. Yeah, I've been having a lot of these discussions, most recently with Patrick McEwen, who I feel is, you know, the world expert on breathing, the oxygen advantage. I'm not pushing his book, but there's lots in there about that. We should not only be inhaling through our nose, and this is, you know, a lot of running coaches, so, you know, you should inhale through your nose and exhale through your mouth. That's bullshit. It really is. It's just totally not scientifically supported. And it takes some, you know, training. And I'm not a marathon runner by any means. But if you look at the Kenyans who win these marathons, they could tape their lips shut. Bill Hang, you know, an orthodontist in California who's had a huge influence on me. He's in his mid 70s, I think, or sorry if, you know, I gave him too many years, but he runs the Boston Marathon every year, but this, with a tape over his lips. He does not take a single inhale or exhale out of his mouth when he's running. And that's really the way we're designed. If you read a book called Born to Run about an indigenous culture that is practicing, living the way they did thousands of years ago in Mexico, they run for 50, 60 miles a day for fun, barefoot. And they don't exhale through their mouth, maybe on occasion, and there's some yoga practices, or I guess for relaxation, so what? That's okay. But, the normal genomically correct way for humans, mammals, to breathe is in and out through their nose. That pressure that's exerted, when air is, expelling through the nasal complex, that's important at the regulation of blood gases. And I know enough to be dangerous about this, but no, we should habitually and train children to habitually breathe through their nose at the earliest possible age. That's how I feel very strongly about it and can back it up.
Yeah, no, thanks for the commentary there, because, and I appreciate you bringing up Patrick. He's done wonders for my career as well, and my functional therapist in my practice has worked directly with him, kind of hand in hand, out there when you brought him to Chicago. So we appreciate you organizing that and bringing so many great resources to all of us doctors who are trying to influence the airway. Mariana,
if I could add one thing, Ryan, to that, the importance of in-out breathing through the nose. CO2 is not a waste product. CO2 is a regulatory molecule. Is that, the way that oxygen gets liberated from hemoglobin has to do with CO2 levels. And if you exhale through your mouth, that really can impair that whole mechanism. So I learned that from Patrick.
Yeah, and so he talks a lot about the Bohr effect. So if anybody wants to look this up, it's the BOHR effect. We talk about it a lot of times with our patients, but CO2 is precious. It is extremely precious. I think in the gases that we can breathe in the air, I think, what is it, Kevin, like 0.02%, CO2, whereas oxygen, we can get that very prevalently, like, 14% or something like that. So it's easy to kind of rebound from an oxygen deficiency. It's a lot harder to rebound from a CO2 deficiency. And those are the blood gases that Kevin's talking about that circulate through our whole entire bodies. And we have these receptors located within our airways that, respond. And, I don't want to get too micro into this, but there's a thing called loop gain. And so we have a lot of, our physicians that have taught us this, and we just have to go back and kind of understand these principles and fluid dynamics and all that. Kevin and Mariana and I could go days talking about this stuff. But I think that's a great point. I think the CO2 level is a great point that Patrick has made us dentists so aware of. Mariana, anything to add to that? I know we're going to try and wrap up here pretty soon.
No, I think you guys covered this part of the topic.
Great. So, this is a great discussion, and, we can continue if anybody has any specific questions, but let me ask you this, Dr. Evans, as far as we have some questions on tooth size. A lot of dentists and orthodontists can become confused or possibly tricked because of tooth size. What priority how do you use tooth size in your evaluation, and how do you prevent yourself from becoming tricked, like you said, in those space cases?
Mm-hmm. So that's a very important question. So you want to position, that's why you have to do that virtual setup, and it becomes very important because you, in patients with microdontia, you could misdiagnose maxillary hypoplasia. So you want to do the setup, and you position the teeth spatially to compensate for the size discrepancy, and also anterior, posteriorly, and in transverse the way they should be, and that will allow you to calculate that skeletal deficiency. But a lot of patients with microdontia have those small follicles of the permanent teeth and will have underdeveloped maxilla. So a lot of these patients, probably for the general practitioner, the best way to diagnose them, have them smile. So they will have very narrow, deficient smile where the teeth are not really supporting the soft tissue, where they have enlarged buccal corridors. A lot of patients with microdontia. And then you have to decide, do you want to open this extra space for premolar in the back, or do you want and bring anterior teeth forward, or do you want to consider some type of veneers or tooth structure correction? So I think this is where the interdisciplinary team plays a very critical role, so you don't miss the skeletal deficiency based on the tooth size. But today, I think we will see more and more patients with smaller teeth or peg laterals or missing teeth because of the jaw deficiencies, and we call them genetically evolutionary advanced because their genes are already expressing the need for smaller teeth because the jaw structures are not growing. But in general, the majority of the population still today presents with smaller jaws, normal sized teeth, and sometimes they look like the permanent teeth are too large. It's all elusive. For those patients with normal sized teeth, a lot of times on the panorex, you will see that the upper canines and premolar follicles are overlapping. If they are overlapping after age 6, I think you should start looking for a maxillary deficiency, especially in the mandible. You can see separately each follicle, and in maxilla you don't. You should start looking. It's not 100%, but it's a red flag that you should diagnose maxillary hypoplasia.
Yeah, those are great points. I really appreciate it. I do want to address a couple other things real quick because I know there's a lot of questions. And, you know, for those of you who have to go, by all means, I know you got to run, but, you know, for me, I'm going to stay on here. I'll tell the wife to put the dinner on the back burner for me so I can come home later. But so one of the things that they're asking about is commercially available functional trainers for children. And I'll give you my take real quick and then we can go into you. So for me, like if any of you logged into my lecture last Thursday on sleep and breathing disorders, right, Kevin, not just sleep and breathing related disorders. So I mentioned the fact that these tools that are commercially available can play a role in therapy. However, it's not a magic pill. Most of the patients that we treat, we're not treating with a magic pill that's just going to magically grow things and solve the problem. So I think behind any good functional appliance case, you're either lucky or you have a really good myofunctional therapist or orthodontist or pediatric dentist or general dentist that has knowledge in this stuff behind it, supporting it, giving exercises in order to work in conjunction with it. So that's my take on functional appliances. I know a lot of companies are out here pushing these things to general dentists and people are buying them and, you know, selling them like candy in their practice. But without the therapy that goes along with it, you know, we're really not going to get the results that we're looking for. And by not doing that, we also may kind of delay, you know, or we may kind of put a bad name to these functional appliances, which can be useful tools in the world of airway and craniofacial development if they're used with the right therapist. Kevin, what do you think about that?
Yeah, well, myofunctional, a guy named Rogers back in the early 1900s, who's all over the medical and dental literature from that time, was really the first person to publish on it. That's really why we have malocclusion. I mean, it you know, as Mariana and I have found evidence for, it just didn't appreciably exist until industrialization. And, you know, there's a lot that goes into that we don't have to go into now. I'd just like to say one thing. It's just like after the discovery of electricity, you know, so many people were like doubting and, oh, you know, because news didn't travel as fast. And then it started to become part of, you know, circuses and shows. And when it caught on, it's like, oh my God, you know, look how life can be so much better if you harness that energy. Well, with what we have rediscovered, because, you know, this stuff was known, before the 20th century, and Mariana and I and others have found literature that supports that. You can do so much good for so many people by recognizing these concepts early in life and implementing them to optimize a child's ability to structurally and functionally utilize their nasal airway, habitually. That's really what it boils down to. And especially in this pandemic crisis era, people who don't mouth breathe, they get these other complications that when they're adults, and that's what I call kids, they're pre-adults. They're going to be adults in a minute. I got two 20-year-something daughters that they were born yesterday, it seems. And these kids, and Mariana's little Stas, he's going to be pushing us around pretty soon. The complications that render this virus to be deadly, has everything to do with the comorbidities that are often associated with mouth breathing and overconsumption of sugar, I might add. So we're just in a position, this is newly discovered, like I said, like electricity. We have discovered it, it's catching on, and boy, the 300 or plus people that watch this, you're gonna be in such good position to help so many little kids who will soon become, very healthy and productive adults. So, God, I'm so appreciative, Mariana. That was just a beautiful presentation. Your graphics, your slides, your evidence, everything is just so powerful. So thanks for including me.
Absolutely. Thank you, Kevin. Mariana, I know people want to get your take on the functional appliances from an orthodontist herself. What are your thoughts?
So I think when we talk about commercially available functional appliances, there are two sides to them that you have to consider. One side is educational. I think those companies have developed very good tools to educate parents and children about orofacial dysfunction, because orofacial muscular dysfunction is pandemic today. Just as much it comes along with mouth breathing, comes along with abnormal jaw growth. So I think the educational tool is very effective, engaging with children, because you want something for these younger children that is going to capture their attention, engage them. So I really compliment to those companies that have done an amazing job with that. The other side of it is effectiveness. I think a lot of these tools are not properly used because they are compared to orthodontic expanders or orthodontic appliances. Those are not orthodontic devices. They are not meant to expand. They are meant to consciously retrain the child to properly use their lips, tongue, and nose. So the purpose of these appliances is not to expand the teeth and treat the crowding. Maybe as a side effect, you could see some minimal effects. So I think a lot of orthodontists in the orthodontic community, they are comparing them to expanders as alternative to skeletal expansion or alternative to any type of functional appliances like a mandibular functional appliance. So I think that's wrong. I think they, now that as we are identifying the need for that skeletal development in the younger population, I think we have to rediscover orthodontics for younger population of our patients that will not respond to traditional protocols. And I think these appliances will become part of it. I use them in my practice for children with special needs that I am not sure will be great candidates for the fixed appliances. So I will use them to introduce an oral appliance through the myotrainer so they can develop proprioception, and we can see if they will respond and be able to tolerate more invasive treatment. So I think they have a role, and they have an important role. But when it comes to retraining, I think what is very effective, and we found just like in your practice, Ryan, is working one-on-one with myofunctional therapists that is really engaging and customizing the need for retraining the muscles for each patient. So I think working just like with speech therapy is effective when you work one-on-one. So this is the same. We are working with the muscle. It's my functional therapist is a personal trainer for your face. Just like you go to the gym, not everyone is going to do exercises on their own. You need a coach. That's your coach for your facial development, for your facial musculature. So that role is going to become more important as we realize it and do more research. And I think more practices will have my functional therapist part of that team.
Yeah, I think that's great points. I really appreciate it. So in closing, I just want to say, Mariana, thank you so much. Your lectures are always, like Kevin said, they're so impactful to many of us who are looking to do more of this. You're a fantastic resource in our community here. I'm so blessed to have you. I know Kevin wishes he had you up there where he's from, but you know, I just wanted to say thank you to Dr. Boyd as well for logging in here. And if any of you guys want to see more of Kevin on stage, he does a lot of courses as well, but I'm going to do a little plug here for our 4th annual Pediatric Airway Symposium. 2020, it was supposed to be. We're kind of in the works of reworking the dates there. So we have some amazing lecturers who will be on stage for our symposium. I think we're going to reschedule to April 2021. Dr. Evans will be a part of that. Dr. Phelps out in California, Dr. Clower, Dr. Boyd, Dr. Lagmani, Dr. Olmos, you name it. Dr. Zaghi will be there as well. So all you guys who are interested in tongue ties. So, you know, I'm really super excited for that. So you guys can all hopefully mark your calendars once we get that date out there. But again, you guys, thank you so much. And thanks, Kevin, for jumping on the panel. You guys, you have any closing thoughts, Dr. Evans?
Well, thank you so much for organizing the series of these webinars and spreading the word. I think we need more doctors like you, Ryan, general practitioners that are going to really be the core leaders in managing these patients from the interdisciplinary standpoint. I think there is a big role that the general dentists will be playing, and you are going to be a very good example for many practices and many general dentists that are getting into this area. So we are also very lucky to have you, and very excited on the progress of the adult and pediatric patients that we are seeing, and we are going to continue taking records on and monitoring. And we also have, for the orthodontists, oral surgeons, and periodontists, if anyone is interested to learn a little bit more in detail on the skeletal expansion, our next course is only 1 week away. So you are welcome to contact me with any questions, any questions that I didn't answer today. I will be happy to answer them through email, Facebook. I'm always available. So thank you so much. Thank you for having me.
All right, guys. Well, I think we're going to wrap up. Dr. Boyd, do you have anything for us? Or
Yeah, you know, I want to echo Mariana. Ryan, you're amazing, man. I mean, you have put together a consortium of people, and I would just like to say we have started a movement. I don't know if you've gone on the AAPD chat line, but we want to put together a concerted effort to decrease public need and demand for children's caries-related disease repair, okay? Pediatric dentistry per se is driven right now by problems associated with sugar overconsumption and tooth decay, need for pulpotomies, crowns, fillings, extractions. And what needs to happen is that demand needs to go down. Tooth decay could end in a generation like childhood obesity could. I came into healthcare as a dietitian, okay? And these things are really important to me. And we want to increase the demand for sleep airway hygiene related, you know, optimizing a child's airway at the expense of not doing, not needing to do. I mean, the demand is still there, and we have to put out the sugar fires. but do some fire prevention. I want you to come aboard the good ship Endeavor, we're calling it. So more later, but some of the people that are helping organize this are on this webinar, and Mariana as well, I think can become a big part of this movement. So stay tuned, and thanks for the opportunity to share.
Yeah, thanks so much, Kevin. And here is the website that he's talking about, AAPMD. It's a really great organization. So if you guys haven't looked that up already, go ahead and look it up. It's amazing. So, all right, well, I think we're gonna finally end here. We might make it home for dinner. So thank you, Kevin. Thank you, Mariana. And for all of you guys who have been logging into the CE series, we will be back tomorrow at 1 o'clock for creating contagious culture within the office. So hopefully we'll see you all then. If not, we'll catch you on a future lecture. All right, take care, guys.
Thank you. Thank you so much. Thank you.